Yeah, we're going to switch gears, I think, a little bit and talk about urogenital fistulas. And I'll use the term urogenital just to say, you know, any kind of fistula with the urinary tract and the genital system of women, basically the vagina. And so, because sometimes we're going to switch over to vesicovaginal, right, be more specific and less specific. So that's how we're going to try to stick with. Associated conditions. This is basically the things that could happen and could then be associated with fistulas. Honestly, saying that it's definitively the causative reason, the cause of a fistula is a little bit harder, I think, to say, but certainly the associations are there. And we pretty much think we know why it's being caused, but we don't want to use that very definitive terminology. So obstetrical conditions are not so much what we see here. We'll talk a little bit about what's happening in the world as well. But the most common obstetrical condition that is associated with a urogenital fistula is certainly prolonged obstructed labor in the world. Not in the United States. In the United States, it's probably more things like placental abnormalities, where the placenta is either growing through the uterus and perhaps even into the bladder. Unfortunately, we have many cases like that at Vanderbilt. Repeat cesarean sections is another risk factor because of the abnormal way things heal sometimes. So scarring occurs, etc. Cesarean hysterectomy is sort of an emergency situation by and large, and because of the distortion of the anatomy, it is certainly more likely and possible for these abnormal communications to occur. Operative vaginal delivery, not so common, but certainly can happen if there's a really bad genital trauma to the system, especially in the anterior vagina. It's even been described with cervical cerclage, and in case you don't know what that is, that's sort of putting a suture around the cervix to keep the pregnancy from coming out too early. So other associated conditions that are not necessarily obstetrical in nature are things like hysterectomies, even myomectomies, which is just shelling out the fibroid from a uterus, leaps, which you've probably heard of, even suction DNC can kind of go awry. Certainly suburethral slings, and a special discussion about mesh could probably take another hour, so we won't talk about that as much, but certainly whenever you use a mesh product, there's abnormal healing, there could be barriers to proper healing, and therefore that is of a special interest to us. Even more so, mesh-augmented prolapse repairs, especially in the anterior vaginal segment, can certainly be a concern for us. Anterior colporrhaphy, which is sort of a fairly standard surgery for anterior prolapse, also because any kind of surgical injury can cause this, right? Even periurethral bulking agents have sometimes been caused. You wouldn't think that, but it can certainly cause a urethrovaginal fistula. Birch-Culpo suspension, urethroδιverticular repair, if the healing isn't as expected and as hoped, can certainly also cause a urethrovaginal fistula. And even ureteral stents have been shown to cause ureterovaginal fistulas. Not very commonly, but can. Then in the realm of pelvic or more medical conditions that you may actually see in your offices, endometriosis, it's a very invasive type disease, endometriosis, and can certainly burrow through a lower urinary tract. Gynecological cancer, of course, also is an invasive process and can certainly do that. Pelvic irradiation is very well known for causing fistula and, of course, makes our life much more difficult in fixing it. And we think my best explanation for that is the microvasculature damage that occurs with pelvic radiation long term. Then there's a smattering of other less likely things, to be totally honest, more curiosities than anything else. So you could see there in Behçet's and bladder stones, infections that we don't see too much here in the United States. I've seen an intrauterine device actually kind of entering into the bladder. Certainly neglected pessary. Actually, Amy Hull did her dissertation on figuring out a safety mechanism to have pessaries not forgotten in the clinics, right? Because we certainly see neglected pessaries cause not just vesicovaginal fistula, but also rectovaginal fistula, depending on which way it's going. There's certainly other foreign objects, association with mesh, accidental trauma, even sexual trauma, unfortunately, can cause that. And then there's installation of mitomycin C that has been reported maybe once or twice, and congenital reasons. So then let's talk a little bit about the anatomical classification of urogenital fistulas, again, going from the overgeneralization of what a urogenital fistula is to the specific anatomical viscera that are involved. So vesicovaginal, of course, is the bladder and the vagina. Urethrovaginal, pretty obvious. There's a vesicouterine, even vesicocervical, kind of depends on how specific you want to be. And you could get more complicated even than that. We, of course, will not be dealing with all of these things. We're going to sort of focus on a few of the more common ones. So this is a British series of urogenital fistula cases from 2011. Paul Hilton is pretty well known in sort of the fistula circles, and so he just talked about his experience for the past 25 years or whatever, and you could see the breakdown. That's the reason I wanted you to see that the most common one is certainly the vesicovaginal fistula at around 74%, urethrovaginal fistula is around 11%, ureterovaginal fistulas at 6%, and then a smattering again of others. Vesicouterine is sort of unique to C-sections and things like that, and then the really more unique ones lower down. So that's just so we understand what we're dealing with. Certainly, no discussion of fistula is really makes any sense without understanding the anatomy a little bit. So I don't have a pointer, but if you look at the uterus and the cervix there, then you could see that the anterior vesicouterine pouch there, that's going to be the area where the future vaginal cuff will be, meaning we take the uterus and the cervix out, then we take the anterior and the posterior vagina at the very top and basically suture it together. So that means that there's going to be a suture line that is trying to heal. And if it's trying to heal, of course it heals next to the bladder because that's where it is. But if some misadventure of healing occurs, you could easily see why most of our fistulas related to hysterectomy will be above the trigone, because you could see where the ureter orifice is there. Again, I wish I could point. Wait. No, you're not going to see that. I tried. And so that's why most fistulas post-hysterectomy will be above the level of the inner trigonal ridge.